Finally, looking at expectations. Many patients come to me unaware of why they were referred. I wish more families had a chance to consider palliative care before the crisis in the ICU. We've been selling medical care through TV programs for several generations now. People's expectations about what can be done, what should be done, are often misaligned with what's possible. We also have had problem being transparent with people about what their expectations should be. We need to start talking to people about not only the benefits of surgery, but also the particular problems that might be associated with it. Talking to them about preparing for knee surgery before and being ready to do rehab after as a prerequisite for getting the surgery at all. So the idea of getting alignment is really important. We developed a tool here that we use in primary care, but it's just as appropriate at an outpatient consultation, which is, okay, you've just seen the consultant, they've done an assessment of you. Let's figure out what was the consultant getting at during today's visit? How did it go for you? What questions do you have? What do you understand that you need to do? What do you think you can do? What kind of support do you think you'll need? These are questions that we have a medical assistant ask or a nurse in the office after the provider has left the room to get a good idea about what kind of help the patient will need, and also to make sure that you've dealt with their real concerns. This can prevent losing the patient to care. More importantly, it can prevent a patient who after a procedure is unhappy with what's happened, hasn't met their goals, and can create a lot of extra work and probably unnecessary hospital care. So this is a usable technique. It's got a script for your nursing staff to use. And as you look at the questions, the obvious ones you'd want someone to ask your elderly aunt when she was at the hospital. We have a lot of programs now through our organization and others looking at end-of-life issues. We've been doing community consultations. We've been doing work with clergy and hospice workers, and also with long-term care professionals. Subspecialists need to be aware of these things as well, because very often at that last 3 days of the patient's life is in the hands of a subspecialist who may have been called in very late in the care and now is facing a patient and a family that really weren't prepared for what they now have to discuss. And there isn't a relationship to do that. So connecting subspecialists to these programs, giving them an idea about what they do and how to use their tools will be very helpful for the subspecialist in the intensive care settings.